to have a little recall of body water distribution, where about 2/3 of our body water is found within the cells, okay? And so intracellular here is about 2/3, extracellular will be about 1/3, okay? So of the remaining, about 80% of the water exists as interstitial fluids, and 20% is going to remain as the blood plasma. So this accounts for 7% of total body water of plasma, and then 28% of interstitial fluid, okay? And so osmotic forces are going to control the movement of water between the interstitial spaces of the capillaries, and so this ultimately is what will affect our blood volume. And so urine formation and water intake, such as with drinking, play a significant role for our blood volume, where the fluid is always going to be circulating in a state of dynamic equilibrium. So capillary exchange is going to be a very important variable for regulation of interstitial fluid. And so capillaries are what exchange occurs through or between endothelial cells. The diffusion is going to be osmosis primarily, and filtration are going to be the primary means of capillary exchange of different waste products and nutrients and water. Okay, so filtration is going to move materials out of capillaries, and osmosis will have them move in. And the net movement of fluid is going to occur from the blood into the tissues. And so the fluid that's gained by the tissues is removed by the lymphatic system. The return of the fluids on the venous end is not 100% because 10 to 15% remains in the interstitial spaces and will enter the lymphatic capillaries. And then, though, ultimately that will be returned to the venous system. So the net filtration pressure is going to be the hydrostatic pressure of the blood in the capillaries minus the hydrostatic pressure of the fluid outside of the capillaries. So our tissue cells receive a continuous supply of glucose and other plasma solutes that are filtered through endothelial channels in the capillary walls. Okay, so filtration results from blood pressure within the capillaries, and so this is what is the hydrostatic pressure. So when we look at hydrostatic pressure at the arterial end, this is about 37 millimeters of mercury compared to the venule end, which is at about 17 millimeters of mercury. The hydrostatic pressure of interstitial fluid is about 1 millimeter, and so the net filtration then is a subtraction of the two. So 37 minus 1 would be the 36 millimeters of mercury at the arterial end, and the 17 minus the 1. So we're at 16 millimeters of mercury at the venous end. So when we look at fluid exchange across the capillaries, so here we have our arterial end, here's our venule end of this fake capillary, and so we have osmosis that's going to be drawing water in, and then blood pressure affecting it, so we have a net movement out of fluid from the capillary due to the blood pressure, okay? So this is greater than the movement of fluid into the capillary due to osmosis. So that's why we have a greater movement of fluid out than into the capillary at the arterial end, okay? So now this is, the opposite is true though for the venous end, okay? So at the venous end though, we have a greater movement of materials into the capillary versus a lower blood pressure out of that capillary, okay? So we'll have now movement of fluid that is going to enter into that venous end, okay? And then here at stage 3, what we have is about 1/10 of the volume of fluid that's going to pass through this capillary is actually going to go into the lymphatic capillaries, which are going to be surrounded by all these venule or the capillaries of the cardiovascular system, and where we have 1/10 that's coming out, but 9/10 is going to return into that. So that accounts for that 10 to 15% that's going to leave into the lymphatic capillaries, and then 90% is going to return within that venous end of the capillary. So some problems that can occur is edema. And so I'm sure many of you have heard of this condition before, where edema is going to be excessive accumulation of interstitial fluids, all right? And so there's many different factors that can cause edema. One of them are high arterial blood pressure, and so this is going to increase capillary pressure and cause excessive filtration. Another cause is venous obstruction, and so this is sometimes due to thrombus in a vein or mechanical compression of a vein, such as with pregnancy, and so this will increase capillary pressure. Third cause is leakage of plasma protein into the interstitial space, and this is due to decrease in osmotic flow of water into capillaries. A lot of symptoms of this too include inflammation and allergic reactions can be a part of this due to increased capillary permeability. Myxedemia is going to be another cause, which is excessive production of mucin in the extracellular space, and so this is primarily restricted to hypothyroidism, so quite uncommon nowadays, but still is a cause of edema. Decrease in plasma protein concentration. This is very common with liver and kidney diseases, where the plasma proteins are excreted in the urine. And then lastly, obstruction of lymphatic drainage. So big example of this is elephantitis in parasites, and also with surgery, such as with breast surgery, causing lymphedema. And so here, let's look at an example. This would be a cause of elephantitis, where we have an excess of fluid that's occurring and pooling at the lower extremity, and this is due again to a parasitic virus. Uncommon in first world countries, but in jungles and third world countries, we actually do see this quite often still. So let's talk about what actually regulates blood volume. And so kidneys are going to be a big factor in what regulate them. So for the first thing, the formation of urine does begin with the filtration of fluid through capillaries in the kidneys within that glomerulus. And so we have about 180 liters of filtrate is removed across the glomeruli per day, but only 1.5 liters are actually removed as urine throughout the day. So this means that 98 to 99% is reabsorbed back into the vascular system, and so we're only excreting 1 to 2% as urine. Okay, so then the amount of fluid that's reabsorbed is going to be controlled by different hormones, and we'll spend a little bit going into them, and the sympathetic systems in response to the body's needs. And so the percentage of the glomerular filtrate that's reabsorbed is adjusted to the needs of the body by hormones on the kidneys. And so this is the big contributing factor for homeostasis of blood volume, all right? So for example, when we have a decrease in sympathetic stimulation, this causes vasodilation, so it increases blood flow and then increases urine production. So we have different stretch receptors in the atria that are going to respond to changes in blood volume, and that's going to regulate the sympathetic activity. And then this is all controlled then because of homeostasis in a predominantly negative feedback loop. So now let's examine some of the hormones that are involved. So the first one is antidiuretic hormone, ADH, or vasopressin. And so again, this is produced by the hypothalamus, and then it's released or it's stored into the posterior pituitary gland, and then it's released from the posterior pituitary gland when osmoreceptors detect an increase in plasma osmolality. Okay, so plasma osmolarity can then increase due to excessive salt intake or dehydration, and so those are going to be the triggering factors for increasing this hormone. So then this increased plasma will also induce increase in thirst, and so ADH is going to stimulate water reabsorption. Okay, so here we have increased water reabsorption within the kidneys, but then this is also the vasopressin part because it constricts the blood vessels. All right, And so the increased water intake and decreased urine formation then are going to be a result of the increase in ADH. And this is going to then increase blood volume and then also increase blood pressure. So the blood then is going to become more dilute, and then ADH no longer is going to be released because of that negative feedback fashion. So the stretch receptors that are found that we have though that detect this are going to be in the aortic arch and the carotid sinuses, and also these will inhibit then ADH release. Stretch receptors in the atria also are going to stimulate the release of another peptide called atrial natriuretic peptide, which will increase the excretion of salt and water from the kidneys to reduce the blood volume. Another system that is involved in blood volume with the kidneys is the renin-angiotensin-aldosterone system. So this is detected when we have low blood pressure and low blood flow to the kidneys. So the cells within the juxtaglomerular apparatus are going to secrete the enzyme renin, okay? So renin is going to be what converts angiotensinogen into angiotensinogen 1. Okay, so then the next step of this is where we have angiotensinogen 1 is going to be converted into angiotensinone 2 by these ACE inhibitors. Or I'm sorry, by angiotensin converting enzyme ACE. Okay, so then what angiotensin 2 does is it has many effects, but all in all, they are going to raise the blood volume and raise the blood pressure. Okay, so this is done by vasoconstriction of the arterioles and the small arteries, and so this is going to increase total peripheral resistance. All right, so from that, that's going to also stimulate thirst centers within the hypothalamus. And so this is going to stimulate production of aldosterone in the adrenal cortex. And so salt and water retention by the kidneys will increase. And so the effect of aldosterone will be to increase blood volume, whereas angiotensin 2 will have a direct effect on the arterioles, thus to increase the blood pressure. This can also work in opposite direction to reduce blood pressure. However, the main response is to increase blood pressure and increase blood volume when we have the stimulus of the low pressure. And so this will continue until our blood pressure goes back up, and then this is no longer detected. And then the last regulation of blood volume will be by atrial natriuretic peptide, or ANP. And so this is produced by the atria of the heart when it is stretched and is detected from high volumes or increased venous return. So this promotes salt and water excretion in urine in response to increased blood volume. So here is our stimulus, so increased blood volume. But this is also termed the diver's effect too, where ANP is stimulated. And so when we are immersed in water, so what happens is that we have an increase in venous return. So this increases the stretch of the left atrium. And so from that, what we have is an increase in ANP. And this is going to produce and promote salt and water excretion, all right, into the urine in response to the increase in blood volume. But this also inhibits ADH, the antidiuretic hormone, or vasopressin. And so from decreasing that, that's going to decrease the amount of water reabsorption. And so all in all, this is going to then increase urine volume, but decrease blood volume. And so this will continue in a negative feedback fashion until our venous return is back to normal. So after some time, when we're, such as we're in the water, then we don't have that sensation of having to urinate frequently. Okay, so this is going to be, however, an antagonist to aldosterone, where aldosterone is going to decrease sodium in water excretion and thus decreasing urine volume.